Hello everyone and welcome back. Today we have another interesting case. 75 years old with white dense cataract, light perception, mid-dilated pupil, glaucoma under eye drops with light colored iris and swallow anterior chamber. He was prescribed with prostate drug for over 30 years. I'm gonna proceed with iris hooks placement with trypan blue dyeing and hopefully with the intraocular lens inside the bag. So let's see how I proceed. So we place the first iris hook below the iris, again all the others. First the incision, as you can see, then with the use of the McPherson and the Colibri we are placing the second one. We're securing it, but we do not pull it a lot. We are waiting until we place all of them and then pull them and make a nice dilated pupil. We are placing the third one and then the fourth one, all with the same concept. We are doing the side ports. In this case, my side port and the main incision were not so good due to the iris hooks. The main incision, the iris was close to the cornea, so I didn't have a lot of space to pass my 2.75. I'm placing the trypan blue into the anterior chamber. I'm letting it for around 30-40 seconds in order to have a good visualization of the anterior capsule, and then I'm washing it out with the viscoelastic. So what's the next step? It's the capsulorhexis. At this stage we should be sure if there is edematous or non-edematous nucleus. I was not sure in this case, so every time that I have a white cataract, I'm doing a small rhexis at the beginning in order to see if there is smoke and fluid coming outside from the anterior capsule, from the nucleus. At this case, when I had the small rhexis, I didn't have any tension, so I did not use the IA in order to drain the fluid between the nucleus and the anterior capsule, and I continued directly with the curvilinear capsulorhexis with my Utrata. I did a small rhexis, which was challenging because in the phacoemulsification, when I was trying to aspirate the nucleus and divide them, it was difficult to bring them in the anterior chamber. And then I'm doing the hydrodissection, hydrodelineation. You don't actually do a lot of hydrodissection, hydrodelineation because in white cataracts the epinucleus with the nucleus are one, so you don't have any remnants. When I'm doing the hydrodissection, I'm ready to start with phacoemulsification. I'm using the stop and chop technique. I'm placing the second instrument, and without a lot of tension, because the capsulorhexis is small and we want to have the integrity of the capsular bag, I am dividing into equal pieces. So when I try finally to aspirate one of the two segments in the anterior chamber, in order to minimize the ultrasound, I'm doing sub-chop with a second instrument, as you can see here in the video. Again, I'm aspirating, I'm sub-chopping, I'm aspirating, I'm sub-chopping. As you can see, there is no epinucleus, there is no remnants. I'm just using for the cortex the IA to aspirate the remnants. And without any problem, with the integrity of the capsular bag, I'm ready to place the viscoelastic and place the intraocular lens inside the bag. I'm placing it correctly. Then I'm aspirating with the IA the remnant of the viscoelastic, and then I'm ready to do the edema to the main incision and the side ports. So in summary, I would like to advise that the residents should not be afraid to use the iris hooks. When we see a poor dilation or a mid-dilation and we are not sure that we're gonna manage the cataract surgery completely and successfully, better is to spend 20 minutes, 15-20 minutes in order to place the iris hooks and be sure that you will have a nice dilation. So these are my advices and thank you very much.